All right. So the goal of dessert was if somebody tells you, did you ever get anything out of Dr. Julius's lecture? You go, I did. So, anyway, that's beside the point. All right, so let us talk about hepatitis. And I think I might look for a slide where I can write. So like any other virus, we know what we know. You've grown through the corona. We've talked about other viruses. We can always get the nucleic acid itself, the antigen, which is protein, the antibody response, which is the patient. There is a tropism for all viruses. They love a certain cell. They have to get there a certain way. And then they'll spread after using that cell for production or whatever else. And anyway, and they'll basically run into their cell or head to their cell. They'll use that cell, and then they have to get. So tell me the way you usually think of hepatitis is spread. Needle and blood. But if I looked at the hepatitis here and I circled that one and this one, do you know how those spread?
Fecal oral.
Right. So how do I get fecal oral out of the liver? What's going to go into the intestinal tract? I mean, how does it connect to the intestinal tract? Right. So there is a way of infecting the bloodstream out of a hepatocyte or the bile stream out of the hepatocyte, and it can get to the outside a different way. So let's start listing these a bit. Fecal oral, fecal oral. Of all of these, which ones do not have carrier states, which means you get it, you get over it. Right. So we're kind of getting a feel here, right? Then which ones are blood? And which one needs the carrier state of B to be infected? Right, good job. And then which one has the worst stealthy carrier state that could cause problems later on? C. That's the one you always hear about where they say, please test, you don't know, it's low grade, this, that. So these have carrier rates that are, a little higher up here. And then this one really implies on the B carrier rate because it's enveloped in there. Okay. All of the reactions you're going to have to any of these is your immune system. So when you have hepatitis, the itis or the inflammation is your lymphocytes. Which ones? T4 or T8? T8, killing off the hepatocytes. So that is now the less immune system you have, the less inflammation. But the less inflammation, the more the persistence of the virus. So if you have a child who gets from mom hepatitis B, as the T cells are coming from the thymus and learning the whole body, they go hepatocyte, hepatocyte, even the one with the virus marker on it, they go hepatocyte. You see the self. And these folks will shed virus all their life because it'll live, it'll knock off of a cell, it'll go to the next cell, and these people will be low-grade carriers all of their life. So it's our immunity that does everything with regard to hepatitis. So like anything else, like any other viral, any other immunology, we're looking at the infection and the way to detect it, or the way to detect the host response. So we can detect a virus, or we can detect the host response. And all of this is years old. I mean, we're not talking 4 years old. This is, stuff we know. So let's talk about it. Hepatitis is inflammation of the liver. It is not due to the virus. It is due to your immunity to the virus. Okay, we already talked about them. There's a lot of different viruses. This is the group we're going to talk about. Hepatotropic. Tropic is it likes it. Tropism. Hepato is the hepatocellular hepatocyte. Can you get hepatitis for a lot of other reasons? Absolutely. Just like if I test you for mono and it's not mono, it could be CMV. So if I test you for hepatitis and it's not a hepatitis virus, it could be CMV or it could be Epstein-Barr or otherwise. You can injure by what it detoxifies. You can injure by your immune system. So there's a lot of different ways to get hepatitis. And just like we talked about with virus, what kind of cold do I have? Well, it's not corona. And, well, it's not corona. It's not, COVID. The same thing with hepatitis. It's like, what do I have? Hepatitis. Well, it's not this, then could be autoimmune, could be anything else. This is what we're going to talk about. So in hepatitis, what do you get? Fatigue, fever, myalgia. Notice these myalgias and fever, it's all part of the immune response. So when you feel achy, because the interleukins that are working are going to make you feel bad. Loss of appetite, vomiting, diarrhea. I mean, it's really a viral illness. It's the virus saying, we're here now. It's all about us. React to us, and then the whole body is reacting to it. And you feel like crap because you're obviously trying to fight the virus. You may or may not have right upper quadrant pain. Here comes jaundice, dark urine, and things like that. And notice asymptomatic infections are 10 to 13 times more common than symptomatic. That's young age, and that's what you see on the news. I know you watch the news, but that's what you see on the news when you have people say test for hepatitis C, because it can be below symptomatic and the person's cooking along with it. We'll talk about the cancers that can go. Here's the ones that don't have the carrier state. You guys are good with that. And the chronic ones, which are obviously B, C, and D, maybe some E's and immunosuppressed. These are the ones that anytime a cell turns over and turns over and turns over, the DNA could change and immortalize the cell. And when it immortalizes the cell, then you're off and running to a tumor. Okay? That is normal liver. This is cirrhotic liver. Normal liver has all hepatocytes. Cirrhotic liver has hepatocytes with scar tissue. So it looks like a cobblestone. That is the liver's way of saying, we're trying to replace the cells that are dying off, but at a certain point, we have to put down scar. We can't keep up. And a lot of things can happen as far as liver goes. If you don't have ammonia detoxified from your proteins, there's your coma. Even the breath that might smell a little bit abnormal. If the blood vessels don't course through a cirrhotic liver, there's your varices, including stool blood that comes out. The spleen gets big because it drains near and through and around the liver. Ascites is liver sweating, so it just doesn't make what it's supposed to, and you can have fluid, not in tissue, but fluid in spaces, which is your peritoneal space, as you see here. A lot of different issues related to anemia, as far as men are concerned, not breaking down endogenous steroids and getting more an estrogenic effect than a testosterone effect, and a lot of different things. You will probably get yellow eyes around a 1.8 bilirubin. But if you're looking at a patient, look at the palms and look at the eyes, the whites of the eyes, because that's where you're going to see the first tinge of yellow. Abnormal circulation is what you have here. Bilirubin can make you itch. There's your fluid and just really bad with ammonia, really bad mental confusion. Here's the thing you don't want to get, which is a hepatocellular carcinoma. People who have hepatitis have to be worked up with their cirrhosis before they get a liver transplant, because you don't want them having this, because the chances of this going to another part of the body by metastasis is huge, and then putting in a new liver when they have a metastasis already, doesn't save their life. This is cirrhosis, and you can get cancers out of cirrhosis. So this is the cirrhosis. It's this cobblestone scarred. This is the tumor. Notice how the nodules are bigger. This is tumor spreading throughout the liver. So here we go. You already kind of told me about these. Same family as corona, Kelsey. Same family as COVID, hepatitis E. So obviously the biggest virus. That's an RNA. And so is hepatitis A. So we've got kind of that going. Hepatitis B is the only DNA. And I guess I remember that because you need hepatitis B to get D, so you can remember DNA. But and then they tell you which ones are enveloped or not. Notice you have no envelope here, but you have an envelope in the bloodborne. Kind of stuff to just crunch into your mind, like you just did with who has a carrier state, who doesn't have a carrier state. You did the fecal oral, blood and sexual transmission. So in a carrier like B, or in a person infected like C, or in a drug abuser who's affected in a chronic carrier like D, you'll make that and it'll go around in the blood. It'll not only be in tissues, but it'll be in blood. And so blood or sexual or secretions would be the spread in that case. So let's start at the beginning. The death of Chili's restaurant, hepatitis A, seriously. But you guys are too young. I gotta get new jokes because you're too young to remember Chili's. But hepatitis A, you're looking at an RNA, picornavirus, so small, picornavirus. You gave me the fecal oral. And I think that's a good idea too. I didn't even remember that. But we talked about Lyme. You can see the incubation period. If you get fulminant hepatitis, you have a good immune response, and you will have to be supported until your immune system is clearing it all and killing it all. There is no carrier state, there's no chronic hepatitis. And so therefore, there's no hepatocellular carcinoma. And you have your structure. We always look at it. Again, remember, capsid is protein. I can always look and test for some of these. I can test for antigen, but I can also test for RNA. But in this particular case, I actually want to test predominantly during the infection for antibody response. Fecal oral, community outbreaks, contaminated water, and not through mom's blood to baby. Makes sense. And you can come in through, cross into blood. So the portal circulation drains the entire gut. And so your liver gets everything. So if you take a med, your liver detoxifies. If you like drinking your meals, it detoxifies it, whatever the case may be. The liver gets everything and will use everything. And so again, it will cross from the intestines into blood and ultimately get there. Now, we talked about bile and stool, and that's how you'd connect up to shit. It is usually self-limited. It can be really low-grade in kids because their immune system isn't so virulent, but in adults, you could have a fulminant hepatitis, you could have a flu-like illness. That is related to cranking up your immune system. And those are the symptoms of acute hepatitis. So here is, you look at a lot of these are things to kind of think in your mind. Here's your exposure again. Here's your lag phase. Notice you're making virus way before you make IgM, which is your first antibody, and IgG. If someone gets really sick and is jaundiced, elevated liver enzymes, we put them in the ICU and we test and they have IgM only at this point. Wow, they're acute and they're hepatitis A. If they have neither, then it's some other hepatitis. And if they have G only, then sometimes I would like to look at G a week later because maybe they're G here or here, and then it doubles over here. And so you can always look at the response of G to tell you, hey, that was 2 weeks ago versus now. If you have someone say, have you ever had hepatitis A, testing an IgG and an IgM says you don't have it now, M, and you never had it, G. If you have only M, you've got it now with symptoms. And if you have G, I guess I would, I don't know, maybe it is, maybe it isn't. But if everything else is negative, that's the only one, then I might want to test your G a couple weeks later and I'll see it go from a low G to a higher G because you're still in that first infection. You're not memory. So having IgG is a serologic scar. Serology is immunoglobulins, and your body goes, we've had this before. So that's what you think of with IgG. So current infection, IgM. It can be present for a while. So symptoms are huge because it could be around for a while. Total is the G and the M, and that obviously helps you. And if you only had Hep A IgG, there actually is a Hep IgG. You can do one or the other. And again, marked elevation. So why do you get elevation of the serum transaminases? How come? After dying? Yeah, so what are you throwing your enzymes into from the hepatocytes? What? Right. So AST is really big in the mitochondria. ALT is really big in the cytoplasm. So if you have a cell that kind of dies on itself, like so, it'll leave mostly cytoplasmic ALT. But if you have a cell that totally blows up, then you'll have both. And usually AST is really high. So if you have necrosis of the liver, ischemia of the liver, AST is way above ALT. Alcohol tends to really knock out your mitochondria. AST is greater than ALT. But when you get ALT greater than AST, that tends to be more your chronic hepatitis, where cells individually kind of shrink and just lose their cytoplasmic material. And so here's the thing, you'll remember this. People say, let's do liver function tests. Well, my liver's functioning right. I shouldn't have any transaminases in my blood. So they're actually liver dysfunction tests. Okay, a liver function test to me is, are you making protein, albumin? Are you making clotting factors, prothrombin? That's how good of a function you have. These are liver dysfunction tests. But people say, how about the liver function test? So what people call liver panel. I still don't expect them if I'm healthy. If I'm dying, that's what I see. The cells are dying. Billy and direct and indirect, because it's going, we're fighting a virus. We really don't have time to conjugate bilirubin. Elk phos is a possibility too. Again, here we are with our capture antibodies. And so what we end up doing is we immobilize an antigen. We are looking for an pentameric or mono, IgM to IgG. We are going to capture with a or develop a color, and that's going to be our positivity. And you can do it a bunch of different ways. But the first thing is you usually have a solid phase. You will either have antigen or antibody on it. You will either be capturing antibody or antigen with it. You will be sandwiching that, and the presence of it means the sandwich is there, and the sandwich means your signal's there, and you develop that signal, pos neg. This is a serologic scar. I got it for life. So if you have an immunoglobulin, you got it for life. Someone says, have you ever had hepatitis? And they do a hepatitis, you should have that as a memory for your body from life. You can detect it with reverse transcriptase, but most people, unless they're really pushed to wonder what's going on, would go back to that. And so, when you're looking at time frame, and you're thinking of IgG and IgM, which this is probably more just IgG. So if you only have IgM, if you only have, no infectivity or otherwise, then you probably had a previous exposure, but you don't have a current one. But that's for IgG. And if you had both, then you're current. And if you're negative for everything, then you've had no infection. So, vaccines, we'll get into it more with hepatitis B, show you what that does to your testing. So treatment supportive, you help the person live through killing off their liver, and then you get full recovery. Obviously, you're preventing this by improved sanitary conditions, hand washing, heating the food properly, closing Chili's restaurants, stuff like that. Yeah, that's a really good restaurant. But they literally did have outbreaks. It was kind of around here in Pennsylvania, and it started spreading out through. This before social media, and everybody said, I'm not going to eat there. And there are vaccines, and I got it before we did mission trip down Mount Salvador, just because of food. So now we go to the opposite end. We stay fecal oral, and we look at hepatitis E. Big calcivirus, cousin coronavirus, fecal oral, again, pretty short duration. Fulminant hepatitis, small amount, that's a real big reaction. There is more so in pregnant women. There is no carrier state to these fecal orals. And there's no chronic hepatitis, and there's no carcinoma because there's no chronic hepatitis, because there's no cirrhosis, because there's no carrier state. And hepatitis, it's calcivirus, so it will look similar to. There's your RNA in the center. And it again is self-limited. You can see where it is positive. We don't get a lot. We really don't get a lot because of sanitary. Usually it's people who bring it back. Since everybody can do world travelers, it's always good to ask the patient or, to know where they've been, where they grew up, where they've been recently, stuff like that. And it's fecal contamination. Very similar. It can be very difficult in pregnant women because of the high mortality rate to cerebral edema, multi-organ failure. Do you know how much liver you need to live?
Third.
It's even less, 15%. It's not a great life, but you can live with it. And so when people are on transplant lists with a very cirrhotic liver, mostly scar, 15% normal, not the greatest coags or whatever, they'll make it, but you really can't overtax the liver because the liver is doing a lot. It's synthetic for a lot of things, detox for everything from your gut, So when you look, multi-organ failure can come from liver failure because liver is like kind of the key. Again, you can do IgM and IgGs, and again, M, as you know from immunology, is acute and G is chronic. Same idea. Acute would be the IgM. A lot of different ways to do it. When we see EIA, it's enzyme immunoassay. So I'm going to have an enzyme that develops my color, but I'm still sandwiching something. I'm either sandwiching the antigen if I'm looking for a virus, or I'm sandwiching the antibody if I'm looking for the patient's response. Okay, so those would be assays. So it just matters what you have on the well. If I have antigen, I'm capturing antibody. If I have antibody, I'm capturing antigen. Antigen is earlier, antibody is later. What am I testing? Okay. Here's the liver dysfunction tests. Here's the height of disease, the height of viremia, the start, where you don't know, and then when you do know, for symptoms, and then of course, or symptoms, and then of course the first response and the second response. So you will get, it doesn't have the antigen would be something like this. All right, hepatitis B. Do you know what the number one transfusion transmitted hepatitis? We list A through E. What would be your guess as the most common missed, even though they call them negative, hepatitis that would give donor to patient blood transfusion hepatitis?
B.
Between B and C, how many for B? How many for C? C is correct. B used to be correct. Okay, so B, when we used to pay people to donate, they used to have a paid donation up until 1974. Hepatitis B was the most frequent. When we went to all volunteer, so all you get is a lousy t-shirt, or no, all you get is a t-shirt. But you don't, or a card, or pizza, whatever. But they used to pay people. And so, and they're actually, and I say this because I was just at the AAVB meeting and they're thinking they might bring back paid donors because people are not donating like they used to. They would be screened, right? And otherwise, but it's like, okay, are we going to pay people? But they don't want to compete with the plasma group, which is paid. And, all alike. And they would hope that people would do it for the good of their fellow human. Anyway, when they used to pay, hepatitis B was big. 1974, we said no more pay. And hepatitis B went straight down because people who might have had not the best reasons to donate or more monetary reasons to donate kind of said, well, heck, I'll do something else. And got out and it went down. But hep C is the number one. So hep B is a DNA virus. So remember that with D, because the D has to be with B. It's the only DNA of the whole group. And now we're into parenteral, outside your gut, not just gut, not gut. Sexual, perinatal, mom to baby, blood, which is usually parenteral. A little longer incubation, not about the same for fulminant hepatitis. Here's your carrier state, and chronic hepatitis is a small percentage. It's almost 50% in C, only 5 to 10% in B. Okay. And anytime you have chronic hepatitis, you can have cirrhosis, you can have some. So big health problem globally. You can see the number in the United States. And modes of transmission vary depending on where you are. And again, you have DNA in the center, but you have other core proteins. You have surface antigen, core antigen, hepatitis E antigen, and those are all proteins. So now you look at what this looks like, and you can have the surface antigen on the surface, the empty particle, and other empty surface antigen particles. So how many people have gotten hepatitis vaccine? Was it recombinant? Was it recombinant one? Did you read the package insert? Yeah, it is. Well, when I was a medical student, here's how they got the vaccine. So why do the allied health or medical students cross the road? Because it was required. But that's why you get your vaccine. It's because we're really good at listening. We're like the only people in society who listen really well. But unless you're at Disney World, like, ma'am, turn the camera on. But that doesn't apply to me. Anyway, but the way I got hepatitis, you got recombinant. So they made a protein, injected into you. How many did you get? 2 or 3? Right. Okay, so I got 2. Here's how mine was got. They got chronic hepatitis patients, chronic carriers, who make the particle, the empty, and this other empty. And this is what you're going to get immunized against, the surface antigen, right? Because just like the spike protein, the outer protein, you want an antibody to surface antigen. You want a surface antibody against surface antigen. That protects you from your needle stick. So what they did for us in 1985, they took people, now I think they were chronic hepatitis carriers. They took their blood, spun it. These floated, these didn't. And then they sterilized it, pasteurized it, and injected it into 70-kilogram medical students. Maybe it was 80 kilograms. And they injected it into us, and that's what we took. And like 4 years later, I went, like, what did I do? All right, anyway, but that was 1985. Anyway, so you guys got a recombinant protein and said, make this antibody. I got the real protein from the heavily infected chronic carriers, non-virus that would be transmissible if it was injected, but empty particles. And that's how we got our antibody. So this is what happens. The virus gets to its favorite cell, the hepatocyte, and will basically come in and try to use the nucleus, try to use the protein, make the core and all the different proteins, be able to put the surface antigen. So here's the production. Anyone who's a carrier, and even anyone who's chronically, acutely infected, may put out intact virus and empty surface antigen. So it was this that I was immunized with. But that's what you end up getting. This is the thing that will cause disease. This will not. Both would cause immunity because they're the same surface antigen and protein. Okay. So they can be markers, the protein antigens that we just talked about, and the levels will come at different times. And so you can put a time frame together depending on if the person has surface antigen, because I'm going to make protein, I'm going to make the virus, I want to encapsulate it. The first thing to appear is surface antigen. As you take over the cell and produce virions. Hepatitis B, E antigen is shortly before the surface antigen, just appears shortly before the surface antigen, appears really after. It's like the highest infectivity. So if you remember anything about hepatitis B, E, it's a highly infected person. I guess that's a pretty good way. Then you have the core antigen. We usually don't test for that. Instead, we test for the antibody to it. And that antibody can be an IgM in the early stage or an IgG as total. So it depends, but IgM will tell you it's current and IgG later. And we can also make antibodies to surface antigen, or what are called anti-HBs antibodies. Those persist for years. So if you have made it through hepatitis, the only thing you may have is anti-hepatitis B. You may also have anti-hepatitis core. but you'll definitely have this. If you've been immunized, the only thing you have is antibody and hepatitis B surface antigen, because you have been given antigen to make the antibody. That's that. So it's about 5% of people get all three and do not get immunity. There's 5% of people who just will not react to those boosters of this, of the low grade, introduction of giving you those three. Because you don't just say, here, this is your immune system. You go here, and then maybe you could spark it one more time, and that third is really for like the last 10 or 5 to 10% of people, and still 5% do not make it.
Do they know why? Because I had to get a double round of shots.
No, they just know there's about 5%. And I don't know if it's like individual people, because when you think of what we respond to protein. That's what that is. And we respond to a certain size protein or otherwise. And that's why they've made the shingles vaccine a little more, they say it really knocks you for a loop because it tries to really stimulate your immune system. The HPV vaccine, they've tied that to a lot of different proteins, and people go, oh, I got knocked out for that. Because the protein itself may not get the immune system, but they try to whip the immune system up by some other things in the mixture. But despite that, they still go, there will be 3 to 5% of people who, regardless, will not respond. And I don't know if that's just, well, let me ask this. Are you a person who always gets colds or never gets?
Your hair?
Yeah, so in that particular case, it may be something that your immune system is just not showing the response, but is still remembering it, But we only have so many ways to test, and the test is anti-hepatitis B surface antibody. If you don't have it, they go, then you must not respond. So you could look at it a few ways. Anti-hepatitis B is the window period for IgM. So if we were looking again at the virion, the most infective, the needle stick or the exposure, symptoms when you're making virus, and the very start of IgM. This IgM happens to be IgM 4. So you make the core in the middle, this is the window, and you make the hepatitis B surface antibody to live forever afterwards. See, but again, it's intact virus. So just like we had intact coronavirus and intact virus being made, we can also identify the P24 antigen on the surface of the HIV, the spike proteins or things like that. As the RNA virus corona, we can identify the surface antigen and the hepatitis B antigen early on in an infection. Again, bead, chemiluminescent, enzyme, whatever. Again, what are you capturing? What's on your bead? What are you capturing? Is it antigen? Is it antibody? What are you sandwiching? That's what you end up doing. So I don't know if this was a is it well, anyway, screening can be followed by a neutralization procedure, and the neutralization procedure is basically trying to, if you had a surface antigen that you were testing and it was close to positive or was just barely positive, you could go and remove all the surface antigen, test the patient again once absorbed, and it should take away the reaction. So you can say that reaction definitely was surface antigen. So here's your solid phase anti-HBs, and you're looking for a hepatitis B surface antigen binding to your anti-HBs. So this is an antigen test. You wash away everything you don't need. You're keeping this, you're sandwiching your antigen, and then you're positive, and that says that you are positive for antigen. Now, if you were to neutralize that, then you go through and you would do something like this to remove as much free-floating antigen as possible. Then your specimen would look like it has no antigen. It would then go through and give no signal. So you'll say, I removed something. So the original antigen that was there, I have absorbed out. And so that tells me I was a real positive, which they do for antigen only. If you are positive for hepatitis B surface antigen, a lot of people will say, before you call the state, before you call the patient, do a neutralization besides repeating it, do a neutralization because you're picking up the earliest. But now we can go even earlier. We get you DNA. And so you've seen the molecular techniques, so you know about DNA. And now forget the antigen, forget the protein, we're even further. And they could even be negative for the antigen, let's be positive for the DNA. So acute hepatitis B, 90%. It's a very small percent that go on to chronic carrier stage. And that's, notice the cases that go on a lot are neonatal. So how early did you get your hepatitis? How early did your body say, well, this is us. This is not a virally infected cell. You do it before you have immune system growth, then you'll be a carrier. And you can continue for the lifespan of the patient. So they can go to college, share, be asymptomatic, never be told, be sharing a razor with someone, and half the dorm gets sick. And it happens, and it can happen. They're not sick, they're kind of asymptomatic as a carrier, but the patient, so when you're a carrier, you could be an asymptomatic carrier or a lightly symptomatic carrier. And the lightly symptomatic is the one that can actually have hepatitis and cirrhosis. And the asymptomatic may not get any. But so anyways, that's carrier state. Because remember, how do you kill, what cell kills viruses again? CD8s, but they're going to do it to a cell that puts out the flag that we are virally infected. And if that flag was out before all the T cells in your body said hepatocyte, it will count that virally infected cell among normal hepatocytes and say, it's always been this. I'm recognizing self. Okay, so it's how early did you get the infection? Transplacentally in the uterus, that's the kind that can become carriers. Okay. So in any virus, seroconversion is it is antibodies and is, something we can look at. So this is classic. You have an exposure. Weeks after exposure, you are making virus and you're having symptoms and you're very infected. Beware of the BE antigen. And then here comes your anti-core, which is in this window period before you make the hepatitis B surface antibody to surface antigen. So you go from antigen to none to antibody to antigen or hepatitis B surface antibody. Okay. Now, that was a typical seroconversion. That's like typical. If you go to chronic, where it's going to persist in your body, then maybe this is people who don't have that T cell wing, can't have T4 because HIV, can't have B cells and plasma cells or immunosuppressant. Look what happens here. You go up with the surface antigen and you actually don't clear that surface antigen. You might make some antibodies, but you never make the definitive anti-hepatitis B surface antibody that says you're done with the infection. So this could be someone that tried but failed. Very different than a carrier who probably won't even try. So that's progression. And again, the chronic is 6 months of hepatitis B, and the carrier state will always have it, will always carry it. They could infect people because they have all these and they're shedding. A healthier carrier may only have this. This does not get confused with immunization. Immunization would be anti-hepatitis B surface antigen antibody. Antibody to this, not antigen. This sticks only an antigen. And they may actually become negative. So they're a healthy carrier versus an infected carrier. Okay, that's the difference of those two. So if we put out everything we could do for a virus, from the DNA really early to the surface antigen next, to the E antigen of infectivity, to maybe some antibody here, the window, and the final antibody, bless you. Here's what you get. If you're acute infected, notice what you have. You have surface antigen and the DNA. Or very infective with the E antigen. And if you resolve your acute infection, notice the two things you have, the big ones, surface antibody and core IgG memory antibody. And you also have the, we don't usually test for them. Chronic carrier state, you gotta have the antigen if you're gonna be a carrier. And you may not even have much low level DNA, just maybe more a chronic carrier state where you're trying to make some antibody, like that one that went up but didn't clear. Chronic active, this is the one that has the ongoing cirrhosis and otherwise. Notice you have the antigen, you have the DNA, you have everything like the original acute phase, but you're not doing anything on the immune side. And then chronic active, pre-core, and here's your vaccinated. That is it. So that's all you get. And that's to stop this as it comes in with the toothbrush or with the blood splash or with that, whatever, headed to your liver. So you're neutralizing it. That's what we do when we give you the flu vaccine. That's what we do with any virus. All right. So if you have acute, support them. What does that mean? Electrolytes, fluids, making sure their blood pressure's okay, whatever, till they clear the infection. If you have chronic infection, you'll see a lot of those. That's the thing that's on the news. I know you don't watch the news, but that's the stuff that's on the news where it says, if you're a baby boomer, get tested for hepatitis C. Because that was the heavy drug. I mean, there's a heavy drug use, and I'm a baby boomer at the end. So I was like a well-behaved baby. But the early baby boomers, you know, the ones in Woodstock and everything else, there's a lot of stuff going on. And these people did carry this infection, or could carry this infection for a long time. And they have a lot of different meds that they could get you. And what are those meds going to do? They're going to interfere with going to the next hepatocyte to the point where it will get you through 3 or 4 cycles and maybe clear it. So it helps your immune system. That's what usually happens. This is what you don't want, which is ongoing inflammation, infection, and cirrhosis, and an organ transplant. You have to be screened. And here's your post-exposure prophylaxis. So if you get a needle stick, don't have hepatitis, then here's that hepatitis B immune globulin. So since you can't make IgG, you get IgG. Hepatitis B IgG from someone who is immune. But otherwise, you know, you would get the vaccine. But the goal is to walk into a patient room with the vaccine. So if you have exposure, you're okay. So there's the vaccines. You know, this is the recombinant vaccine, which you probably got this one. Probably this one. But, and then there's other vaccines, which they tie it to. You can see kids are getting it earlier, so it's tied into all their vaccines. You know, that it just depends. If you're going somewhere third world, hepatitis A and B. All right, so that's B. So D will only be heard in chronic carrier bees. You have to be a carrier to have D use those empty shells of B to set up shop. So D with B. And it needs a super infection with hepatitis B. Okay, so it is sitting there within the empty virions of someone who's making all that hepatitis B. So they're making the empty shells, the ones that you can make, the ones I got immunized with, but it's using it for a different reason. So that was something that was weird when I got my immunization. I'm like, wait a minute, what about hepatitis B? Yeah, because they took people who were chronic carriers, and I don't know, were they drug user, chronic carrier? But I said, no, don't worry, which I didn't. So anyway, hepatitis delta, it's a co-infection, drug addicts. So there's your IV use, blood-borne, and it's really related kind of into chronic hepatitis. So it's a co-infection or a super infection. So what do I mean by that? You get the hepatitis B and D at the same injection and same exposure, or you're a chronic carrier who then gets an infection with D from someone who's shedding D wrapped in B, that you now can do both, and it's now introduced to you. So that's what you end up seeing, and it's really high risk group, so it's high risk behavior. Gotta be cautious. It's caused by a defective virus, and it needs hepatitis B. So, um, so this is the big thing. It provides the envelope, and again, you get it in the same injection afterwards. And that's the co-infection that you get together, and the super infection would be an extra one top of. This is a question how it actually does its damage in hepatocytes. Really not sure. And there is an HD RNA, a marker of replication that's present in all folks. And so that's a molecular test. So when we think molecular, as you bounce around different viruses, some are hinged on knowing the virus RNA or DNA, and others on the host response, IgG, IgM. And we know about reverse transcriptase and the signal and probes and primers and stuff like that. So, you can do an anti-HDV. In that case, it's an immunoassay. The D antigens on the bead. You're capturing IgG or IgM or total, and you're then sandwiching that. Presence of the G or M makes the sandwich, and the sandwich is topped off by a fluorochrome, a chemiluminescent chrome, whatever. And again, IgM versus IgG. So you know the immunology. And then there's hepatitis C, almost there. And hepatitis C is number one for blood transfusion, number one for sneaky, number one for actually never being, we isolated until we got the NAT test. We were always doing antibodies for it in blood. But it's a flavivirus. Notice it's parenteral, so it's part of that blood group. And again, in carrier state. But here is the big thing, the chronicity, which I always think about is 50%. But it's known for its chronicity. And then hepatocellular carcinoma, wherever there's chronic hepatitis, there's cirrhosis. Wherever there's cirrhosis, there's scar. Wherever there's scar, there could be turning over of cells, and malignant cells come out of it. So that's the size of it. And it was called non-A, non-B. Now we're always up to E, and I think F and G and other stuff like that. And transfusion related cases are a possibility, and there's a little blip in there, and they're all getting older, and that's the group that is highest probability. Drug use is huge. Sexual transmission is still there. Transfusion is the one to remember. It's the most frequent form post transfusion. Let's see. There's your baby boomers. And again, there's the one-time testing for that. People are saying, one-time testing. Those of us who give blood have been tested every time. You may have asymptomatic cases, but beware of fulminant cases. But the biggest thing is chronic. So again, persistence. So can people recover? Yes, it's a small percentage here. Can you have cirrhosis? Oh, sure, but it's really the persistent infection, either asymptomatic or chronic. You can move on to these things, which are really bad. Obviously, a cancer that can spread, end stage cirrhosis or otherwise. And the whole point, as far as the body's concerned, the body will say, if I can get over it, clear it, I'll put everything in a row, my cells will divide and I'll repopulate. But if you continually give it, like the turnover of your, if the turnover of your hepatocytes, if they're normally going to turn over and now you're reinfecting, it's as though the body sits there and says, I'm going to have to fight this in the chronic state. And as such, it may peter out such that it puts down a scar and it can't make another cell. That's the problem of chronic infections. Um, cirrhosis and further on. And so we can treat, there is no vaccine. And again, how can we test for it? We can do the IgG, a lot of different methods. We can confirm it. Again, in the confirming now is what we do is we get a blot, just like you have some of those rapid tests, and we have different proteins, and we lay on the plasma and we see if we capture specific proteins to hepatitis C, like 2 or 3 different types, and that would be a positive, it would be a confirmatory. But we can also do reverse transcriptase, we can do PCR, we can tell you how much virus, or is it positive? So we can do a qualitative, is it there or not, by a primer. Or how much is there, which is a quantitative, so viral load. So you see these things are coming up again and again. So if someone comes in and never has an HCV antibody, non-reactive, then they've never been infected. Once they're positive or reactive, the difference between having RNA virus or not means you got over it and you have an antibody versus you are infected and you have the antibody. An HCV antibody is not protective. It's not like hepatitis B surface antibody. It's not like hepatitis A. There is no vaccine, but there also is no guarantee that the antibody says you're done with the infection. In fact, for the most part, it tells you might be one of the chronically infected, because that's usually. So again, if you have non-reactive, then you've never been there. But here's another thing that we don't think about. Remember what you're testing for. So if you say, I'm going to get an antibody test because they just stuck themselves with a needle. Well, if it was recent, then you better go for the RNA because they haven't developed their antibody yet. Okay, so that, remember what you're testing for. But if it's a long time ago, they go, oh yeah, I got stuck with a needle 3 years ago. Okay, then this non-reactive means you never got hepatitis C. Once you're positive, then you're looking at, do you have RNA or not? Are you chronic or are you done with it? Is it current, whatever? And then again, if I have antibody and HCV RNA, then I'm looking more at a current infection. If I'm negative for both, then that really rules it out. So we used to screen for hepatitis C antibody in blood. Now we screen for nucleic acid for hepatitis C and hepatitis C. So we could tell a donor, you're gone. First time donor, usually they're the ones that are positive, unless they had a risk factor between the last time they donated. But if they turn out to be HCV negative antibody and RNA negative, then we use their blood. If both are either positive, then we tell them, we're not using your blood and you may need to go to the doctor for these reasons. And we write those letters to the donor. You can genotype, depending on the types of hepatitis C. That's just for if they're going to get therapy. And again, the genotype is just a specific type, so it'll look different by PCR. By its, this probably is not that important, but if you have hepatitis C, it goes a long time. You can actually develop antibodies that are kind of cryoglobulins or immunoglobulins that precipitate in low function or low temperatures. And hepatitis C is mixed cryoglobulin cause, a real big one. That's renal failure, problems with joints and skin, things like that. And those are the types. So not as much of a thing. What the hell was? And it can be associated with other. So let's take a deep breath. Let's see. If you had this, let us go to, all right, I will read the question. What is a patient with hepatitis B, who is not infective, don't beware of them, and is in the gap or the window period, which one of these hepatitis B patients, A through F, would be in the window period and not infected? Yeah, I like it. Why?
So it has the IgM.
Right? Right. What would be the effective one that you worry about?
The B.
Right. So the absence of that, are you early or later in the window period? Anybody can help out.
Later in the window.
What will come first, M or G of the window, of the core?
M's first.
M's first, so earlier or later? Restate, there you go. Okay, so it's really just, you're getting into your core window. You're not like further along in it, because that's that IgM, that's the first phase.
I was thinking of the windows when the virus is coming down, you're just starting to get the IgM. It's like the end of the window, but
Correct, correct. But if you look at what the window period is, it can be all parts of the core, the M to the G, so I'm just trying to force it more for, remembering M before G. But I see your point. Next one. How about a patient who has been vaccinated? It's hepatitis.
D.
Nice. I like it, guys. All right, so anti-hepatitis B surface antibody. If you were someone who has recovered from hepatitis B, to compare to just the last patient we had, so totally recovered from hepatitis B. Right, so what's the difference? Is it? Of what? Core. Core is natural infection. Surface antibody can be natural infection, actually, or immunization. Okay, so the core says I did see an original, virus. So you can see how they sit side by side. All right, let me hit another one. Patient with symptomatic acute hepatitis B. Symptomatic acute hepatitis B. I like that. Yeah, I think that's true. I could do that. How about patient with infective chronic hepatitis B? Infective chronic hepatitis B. Right, and so I put those side by side because if I'm in the middle of it, I know I'm in the middle of it, I'm still making virus particles, I'm just getting into the window period, but I'm not, out of the infected period like this one. But the difference here is I have the IgG here versus the IgM, so earlier phase versus someone who might have an infective chronic. Because remember, you can make in the chronic either or both of these. The chronic is just known for not having the final antibody hepatitis B. And my last one is healthier carrier for hepatitis B. Healthy carrier for hepatitis B. Right. They're making some antibody. They don't have the E antigen, so for themselves, they're pumping out this, but they're not as symptomatic. But they're a carrier. All right, and if we go back to the serology, here is our original. Here's where we worry about infectivity. Now that can go for a while in different individuals. Here is your window period, this whole thing. And yes, you will get G and M, but M will be first and G will be later. Natural infection will have this. Immunization will have this. Patient over everything will have these two. And yes, we don't test for this, but that really tells you they're over, but it's really the surface again. So. And I think we did this. The only marker for acute hepatitis B in the early recovery phase when all the antigens have disappeared is that IgM. So that was back to patient with hepatitis B who is non-infected and in the serologic gap. Okay, number 2 was markers for recovery are core IgG and anti-hepatitis B surface, which was our patient who has recovered from hepatitis. Patient who's been vaccinated, anti-hepatitis B against that, but that's the only thing. That we do not test for anti-hepatitis B in blood. So anybody who's been immune by immunization will not test positive because they're going to test for the healed side. All right. Patient with symptomatic acute hepatitis B was B. I think we said that because they had the E, they had yet to put out the earliest of IgM. And remember, carrier folks can still have core antibody of varied sizes and still give rise to shedding virus. You're not over it till you have the anti-hepatitis surface. What was 5 is a patient with infective chronic hepatitis. So chronic is the hepatitis surface antigen, and infective will also have the HBeAg and infected particles if we look for DNA. And they may get to the point where they'll have that IgG, that core, but they'll trace particles in core all the way over and continue to have them. They won't have the surface antibody. And for healthy chronic carriers who have the B surface antigen in the core, they lack that BE, which is bad to them and bad to people who are going to catch it. That was bad. Questions? So bottom line with virology is intracellular organism, it picks its cells. You know, T8s are very important. The earlier you get the infection, the more it can be masked to self. The later you get the infection, the more you have an immune system that can't clear it. And your clearing it can lead to the severity of a lot of different illnesses. Pick your poison. You're going to pick the DNA or RNA early, or you're going to pick the host response. IgM always comes before IgG. So that's just virology. So when you're doing a test in serology or virology, knowing what you're testing for. Am I doing a primer for the RNA? Okay, I'm really early. Presence or absence of the virus is what I'm calling infected or chronic carrier. And then when you go to the serologies like hepatitis, what is my capture? I have antibodies, so I'm capturing surface antigen in this case, and I'm wedging it. So I'm looking at this time of the infection or otherwise. So that's what we've done. And you guys, like I said, you've lived through working up a virus from start to finish in corona. What is the best test? What is the test of cure? Those types of things. When I tell you monospot or we do hepatitis, that happened years ago. So we can tell you how it's developed. You know, questions? Doesn't happen. Thank you.
Thank you. Yeah,